I'm so glad to see you again, Robin. Join us on a two-part case study talking about various women and their issues with hormones. Let's start by jumping right in. And there are some cases I think we want to go over as well.
I love talking to Florence because she's so knowledgeable in this area. So I love picking her brain. I was saying how you almost have to, it's like pulling teeth to get these women to do this amazing thing for them, right? To give them back these hormones.
For themselves.
Right.
Exactly.
So that, and it's not, and that's the other thing, they think it's all about the symptoms. No, I'm like, it's not. It's about protecting your heart, protecting your brain, protecting your bones, like all these things. And then you get them on it, and then they're like, oh my God, this is amazing. Like, I feel so good. But then there's still this thing in the back of their head, like, oh my God, am I going to get breast cancer? Oh my God, right? Like, it's really sad. So anyway, I had this one patient, a 57-year-old female, and she's been feeling amazing, on her combination. I think she's on all three. I think she's on estrogen, progesterone, a little testosterone.
And testosterone,
as well. Yeah,
which is very rare. A lot of conventional medical doctors don't feel
so important for
testosterone, yet it's such a great hormone. Of the three, it does the most for the body.
Right, and like I get that some women can't tolerate it, and that's fine. But like, you should at least try. To me, it's like you try and see how they do. Right?
I think in the thousands of women I've treated in the 30 years, I've had one woman who couldn't tolerate testosterone.
Oh, that's good, because I always hear other stories. I mean, I'm not nearly as up in numbers as you, like with treating, but everyone's always like, I hear like, oh, this one had a problem, So I just try it anyway. So I have this female patient, and I guess I was trying to increase the progesterone and estrogen. She was on I think maybe 200 of progesterone and estrogen,
as a micronized, so progesterone, micronized progesterone, 200 milligrams taken every night.
Yeah, before, she's full, and then the estrogen patch, 0.375. So her numbers, like serum-wise, are still very low, very low. So, and especially the progesterone. So I increased her progesterone to 3, and I went up on the patch, to the next dose. So I guess she had some bleeding, which happens sometimes. And so always I get a pelvic ultrasound just to be sure, right? Like a transvaginal ultrasound. And that came back, the endometrium was a little thickened, but probably having to do with her being on the hormones, like whatever. I was going to show you the radiology report. I'm not worried. It stopped. It's all good. And then, a few weeks later, after that happened and everything was fine, she basically calls me and she's like, I have, or she sends me a picture, and she has almost like a cellulitic sort of like bite, like on her right breast, the right breast. And she thinks she has inflammatory breast cancer. I'm like, you don't have inflammatory breast cancer, right? I was like, that's not even where it presents. So she's really freaking out and getting upset. And I calmed her down, and I was like, and she travels all over, this patient. She's like never in one place. So it's like, maybe have someone examine you, get their hands on you, just see what it looks like, because you might need an antibiotic, because I didn't like the way it looked. And it looked like a bite, to me. And then she had this cellulitis. So basically, she got an antibiotic, it went away. It started really going away within 2 days.
Nice.
And she felt better. So then I get a call yesterday or the day before, that now she's having all this breast pain and breast discomfort in that breast, and it's radiating to her armpit, and she's literally having a heart attack.
So let's talk about it. So let me start, as you know, at the beginning, we are concerned when a woman has a uterus and we give them estrogen, it needs to be countered by progesterone, because progesterone's the balancing hormone, right? And we all as women make progesterone usually when we're younger, in our reproductive years, until we go through menopause. We're making the progesterone after we ovulate. As we hit our 40s, many women don't ovulate. Sometimes they still bleed regularly, but they don't ovulate. So to start with your first issue, no, I don't worry about serum levels. I actually think what trumps that is how a person feels and other risk factors. So have I used progesterone even 300, 400 milligrams every night? Yes. But I mainly use that in the setting of withdrawal. So if somebody, I think, has unopposed estrogen, they either have a cyst, and that's not uncommon in women in their younger years, like 40s and 50s, as opposed to later on, then I might induce a menstrual cycle because I want to shed the lining of the uterus, and I would either give them an injection of progesterone or orally every night for 2 weeks, and then induce a withdrawal. Because if you get a uterine lining of greater than 4, I don't find that acceptable.
Right, so her thickness went up to 6 millimeters.
So that's a little borderline.
Yeah.
You can go either way there. Sometimes you just use progesterone and then you stop the hormones, you stop the estrogen and the progesterone, and then you have an induced bleed, and that's what you want to see. So you don't want to keep building up that lining. As far as the rest of it,
So even though she's 57 and she hasn't bled in the longest
yeah, you want to, I can live with 6, but 4 is, much more comfortable.
I know that is, yeah.
And
so what would you do with this patient? Would you repeat the pelvic transvaginal ultrasound?
It depends on the timing. So depending on when you've given her the hormones, I would take a look.
After I increased her. Okay. That's when this happened. It's just the timing was perfect.
So she had the ultrasound after the increase in progesterone or before?
After I increased her, she bled. So then I ordered it.
Okay. So you ordered it.
And this has happened a bunch of times, even with women when I've gone to 100 to 200. This is a good conversation to have.
Right.
It's why is this right? And it's always that it's not coincidental. It happens a lot.
Right,
and so and then you get the pelvic ultrasound and then you put them through a biopsy. It's almost like you're incidentally finding it, but it's probably maybe a physiologic thing that's happening because they're on the hormones, right? If you could explain that would be amazing.
So on a positive note, if they're doing that, they actually are biologically younger because they have the capability of estrogen affecting the lining and building up a lining.
Interesting.
But the first step might be to, when somebody complains about it, or if you think the levels are low, which is not a driver in my case, then I would get an ultrasound. I would make sure that what it looks like. And then I might leave it alone, and I would not have increased her progesterone.
Well, no, I put her back down.
Right.
I put her back down. And then it's just they were just the numbers were still in the toilet. I mean, you're right. You should treat the patient, not the numbers. Then you get
numbers drive us. So there's no question that the numbers are in. So let me tell you my bias so that because it applies to all women. First of all, each one of us is different and we respond to different levels of hormones. Mm-hmm. So you can give 2 women the same hormones. The levels can be different. They metabolize it. They absorb it. Correct. It's based on diet. It's based on lifestyle. There's a lot. You know all of this.
Yep.
So the first thing we do is look at risk benefit for each person. And sometimes the levels of estrogen don't raise or progesterone too much, but if symptomatically they feel good, you might leave it alone. Now, you might look at other variables too, which we can go into. But remember, when we're of a reproductive age, the first week of our cycle, we can have near castrate levels of estrogen and no progesterone. The second week of the cycle, the estrogen starts going up. And so by the time a woman is ready to ovulate, which is usually about 2 weeks before they have a period, it is not counted from day 1 of their period. It's actually backwards because we ovulate 12 to 14 days before a period. The estrogens could be as high as 100, 200, even 300. Yes. There's still no progesterone. And it's only after ovulation that you'll see progesterone rise anywhere from 1 to 20, depending on how healthy the ovulation is.
So it's interesting because, and I think I was taught well when I, was really trying to get my head around and getting teaching around hormones, but I always do check in premenopausal women, especially the hormone levels at day 5, 6, 7 after they ovulate, so that they're in their luteal phase. So that you can get an accurate progesterone. Right. But that's another thing that my patients go to. You see their conventional, doctor or gynecologist, and they're not checking it based on that.
I actually had one of the brightest endocrinologists, but was not a reproductive endocrinologist at Yale, refer me a young patient in her 30s, asking me if she was menopausal. And what happened was the bloods were drawn mid-cycle where LH is elevated. And so I remember feeling uncomfortable because he was one of my professors.
And your progesterone's not.
Yeah, and so because it's very important to pay attention to cycle weeks. Mm-hmm. And some women have cycles that are every 21 days.
Right, so I'll have them do ovulation strips even, and then I have them do it based off of that.
That's all perfect. To deal with this patient, I would likely reduce both her estrogen and her progesterone.
I did. I went back down to the
lower level. Because that was a pretty low level of estrogen. 375 is
I went back down to 0.375 and I went back down to 200 a P. So but now why she's obsessing now about the, now I told her again, she's not my full-time patient. She just sees me for certain things, especially hormones. So she has another concierge physician. And I said, you really should have someone examine you, and you likely need a breast ultrasound if it's really bothering you that much. So I told her to go back to that doctor and, to her concierge primary care doctor. And she's going, I think, on Monday to examine her. And I said, you likely, if it's really bothering you, get a right breast ultrasound to start.
So it's unilateral, one breast, not the other, not both.
It's
her
just
discomfort.
her right breast.
It's where she had the cellulitis.
It's where she had that, cellulitic.
So it could have gotten a bite. You don't know what happened and why she got infected.
Yeah.
That's exactly the path to take because you just want to be sure there's nothing else going on, and it could be an inflammatory process, but not related to cancer. This is not the way it presents.
And she thinks that it has to do, I'm just saying this is where women's minds go. And that's why I just thought it was an interesting case to talk about because she thinks it's, oh my God, the estrogen. And oh my God, you increased the estrogen for those few weeks. And oh my, like it's
she has no perspective because she hasn't seen, but I've seen cases like this. What's a possible next step? And it's really dealing with her anxiety and showing her the before and after is I might stop all the hormones, let her get examined, and then she won't be feeling that good when you stop the hormones. No. So then I would resume it at the lower level and have her understand that there's no relationship here. Mm-hmm. So that I've done also, particularly...
Right, to show her that even off of it, she's having maybe pain or something.
Yeah. It isn't due directly to the hormones. Yes. Now, the hormones can aggravate if on high doses sometimes of estrogen, which she was not on, you can get sensitivity of the breast.
Right, I know you
hear that all the time.
Me too.
But it is offset by progesterone, and it also you can use progesterone cream. So sometimes in these cases where they're really worried, I'm perfectly okay with saying, let's hold it for like a month or a couple of weeks. Let's see how you feel, and then we can resume it slowly one at a time, and we can see how we do.
I like that. And then as far as her pelvic ultrasound, so physiologically, it sounds like she's just responding to the hormone, and she's on a good amount of progesterone to counteract. So
actually, you have her on pretty low estrogen and higher progesterone.
That's what I mean. That's what I mean. She's on plenty of progesterone.
Yes,
right.
No, you did that perfectly.
So anyway, the point is with this, would you repeat this or just what do you think we should do with that?
I don't have the exact timing in mind, but what I would do, thinking it through, is I would probably repeat her ultrasound in a month or two. I might repeat it off the hormones. Like if she's comfortable, I would tell her this, we can go in any direction. Let's see how you do. Let's stop the hormones for now.
Not going to want to.
It's what?
She might not want to.
She might not want to, but let's assume she listens because she wants that comfort zone.
How long do you take them off the hormones?
A minimum of 2 weeks, maybe a month. You can also do a week.
Well, if she repeats it on it, and this just stays the same.
That's fine. She could repeat it on it because you could see what the lining looks like. But if the lining persists or is greater than 6 millimeters, then I might hold the estrogen, keep her on the progesterone, and then withdraw the progesterone after 2 weeks at a higher dose.
And then
at least 200.
And then repeat the ultrasound one more time, another month later.
Yeah, and maybe she'll bleed again. Or if you might not catch it, but she hopefully will shed the lining. Does that
and then
feel
the thickness will go to, I like that.
Don't worry.
All right, so you want to go to the next case?
Yeah.
So this patient, I wanted to show you her blood work, actually. She's a long COVID patient, young girl.
In her 20s?
No. 16. But a lot of these girls or young women after COVID or the vaccine, they developed a lot of issues with their menstrual cycles and dysmenorrhea or amenorrhea. I've seen it a lot. I don't know if you've seen things similar to this. I just want to tell you a little bit of her background so you know. Let's see where we are. Okay, so, now she's 17. She's actually 17 now. And she came in with long COVID. She also has SIRS. She has a history of pandas in the past, but her main symptoms were like chronic fatigue with post-exertional malaise, brain fog, blurry vision, insomnia, joint pain, daily migraines. She also has like a lot of mast cell issues. And I'm trying to think where the thing is about her period. Hold on, let me just see. I'm looking in my note. Okay. So she reports bleeding. She does menstruate every 28 days. She'll bleed for about 5 days. She has heavy flow the first 2 days. She has some PMS symptoms, including bad headaches and cramps. Okay, so that's where we were. Now, whenever I checked her blood, she looked like to me, and I did it how we just talked about the right way to do it during the luteal phase. She would always be hanging out at like I saw her, she had an estrogen of 322 and a progesterone of 0.1. And then, so to me, and you can also qualify this too, I think about estrogen excess as 2 ways. Either your estrogen is still within range, right? But maybe on the high end of normal. And then like you have like no progesterone, or you have very, very elevated estrogen and the progesterone's within normal. So like she to me was more like high normal, but like no progesterone at all.
Does she have any history of any reproductive endocrine abnormalities? Any evidence of PCOS or any metabolic?
She has a history of PCOS. I lied. I didn't tell you that. I'm sorry about that.
You left that
I forgot
out.
to tell you. I lied.
Her menstrual cycles really regular?
She's saying they are, yes.
Have she kept a calendar or one of the apps?
She does the apps, and that's why when I
and
asked
you can
her,
see that?
Yeah, and that's why when I asked her history, she was able to say pretty much she's been regular at every 28 days.
So you can be completely regular. You can even be completely regular.
And
I'm
have
just talking about this. No, and be pregnant. Like, so I have seen all sorts of cases in presentation, because I don't think we don't know what we don't know. But in her case, just on a very low-level point of view, because I don't have the numbers in front of me, it sounds like she's anovulatory, and that means she's not making an egg, and she probably has a cyst, ovarian cyst, that is making enough estrogen, because that level of estrogen, if it's week 2 or 3 of the cycle, suggests that there's a follicle that's overgrown and is still secreting estrogen. And that can cause not the symptoms you said, but symptoms of breast tenderness and growth, discomfort. Sometimes there's pain in the pelvic area, right or left. So I would look for an ovarian cyst in her, and then I would withdraw her. If her progesterone is low.
So that's what I want to talk to you about. So would someone like her be a good candidate for starting some progesterone?
Yes. It doesn't have to be permanent. Like, it could be something, it's used diagnostically to see if you could shed the lining, because she presumably also has a built-up uterine lining. There are other conditions you can look at, like endometriosis and adenomyosis, that could be contributing as well.
So I should just get the pelvic transvag ultrasound on her.
Yes.
And then how much progesterone would you start in for how long?
Minimum of 200. Actually, my go-to levels for menopausal and perimenopausal women are really 100, because I don't think you need to have levels of progesterone, measurable levels of progesterone.
Right.
But in her case,
so you would give her 200 milligrams of progesterone.
At least 200. If nothing, and if she's on it for like a week to 2 weeks, that would be the window. Then you stop it and you see if she withdraws to that. If you did the ultrasound, you'll also have a preview of whether there is a cyst, whether sometimes cysts you have to withdraw the fluid from the cyst for it to go away.
So should you do the ultrasound first and then start the progesterone so you can see what she looks like baseline?
Yes, you want to get the baseline data first. And I would probably repeat her values. If she's that young, she probably, you can look mid-cycle at her LH and FSH ratio to see if you can document that she has PCOS. If she's never had an ultrasound before, not every PCOS patient presents this way, but you might pick up the cysts that are pathognomonic or will document PCOS.
So because I know I have a lot of PCOS patients, they don't have any cysts. That's normal. I mean, that's a common finding. But is that not a good time to check the FSH and LH? Or you have to do it mid-cycle?
You can, but you want to do it at a time that you know what the numbers should look like. And if there's a reversal of the patterns, you'll be able to see it more effectively.
So you have to really send them twice then? Like you want to send them
sometimes,
around day, like if they're a 28-day or like around day 14 to do LH and
or
FSH?
even earlier, like where you're building up and you can see that the numbers are not compatible with where you need to go for ovulation. And then you do it during ovulation to check to see what their progesterone is and if they're actually ovulating.
Okay, so wait, what? So when are you checking I thought,
so you definitely check for progesterone during what would be presumed to be post-ovulatory.
Right.
So you get their cycle.
But I was checking estrogen
dates.
then too.
I don't often do that because unless there are symptoms of pelvic pain, discomfort, and I suspect a cyst, and she might have one because that's a pretty high estradiol level for a young woman who's not being stimulated through IVF. Usually you'll see estradiol levels. It's not uncommon to see 150, 200, 250, but she was closer to 400. So unless she was potentially having twins and multiple follicles were coming, it's much more likely that she has a cyst that's continuing to be active and she's not ovulatory to counter it. So her progesterone hasn't gone up and she may be bleeding. It could be estrogen breakdown bleeding if her estradiol has fallen. So I would prefer to see her estradiol in the first week of the cycle. Because at that point, she should be low estradiol. And if she's not, then she's a constant estradiol and she's just bleeding on somewhat of a irregular basis because we don't really know the dates,
and so
right?
for women that do have estrogen excess, right, do you keep them on a certain amount of progesterone for a certain amount of time or no?
Let me address that in a different way, which you probably know. I like the basics. Like, I really want to know the dates because a lot of times, just like we know somebody thinks they're bleeding heavily from their mouth or a mucous membrane. We know that it's just because it looks like that, but it really isn't, right? The same thing is true of dates and following your cycle and symptoms. Unless you can absolutely say, listen, I need to know the last month or two, and then I want to follow it in the next month or two, it's very hard to make sense of it. Once you get that health story and you see what they're doing, you can figure out, I know you can for sure, what is actually going on and what's the best way to proceed. Where do you start? In her case, it's a little too unclear to me still what her periods were actually doing. I'm not saying that they might not be completely regular, but I doubt it. If she has this kind of pattern, it would be hard to trust that they're absolutely regular. So if you're not getting the facts from her, I would ask for that.
So you're saying, like, for her, she should get her estradiol checked the first week of her cycle.
Yes.
Meaning, like, after day 1 of bleed or something.
Or you can do day 3 where you can also check on an FSH and LH, right?
You do it then, too? Because you said mid-cycle for the FSH.
In fact, progesterone can sometimes be elevated the first 2 or 3 days of your cycle if you've ovulated and it's a good ovulation. So I would check it at different points in the cycle, but I would start by looking, does her estradiol fall? Because that estradiol is pretty high. And you're checking it at a time in the cycle where you can't rule out if there are multiple, eggs and follicles, or she has one big cyst. She could even have a cyst. She can even have endometriosis because her long COVID symptoms could be masking other conditions that she might have underneath.
Yeah.
Did she start like this with her menarche, with her first menses? Because that's another good question. When was her first menarche? How were her periods at the beginning?
I have it. It's just in the chart, but it's not.
Well, we could circle back to it when there's time.
But that was like super helpful. This was the most insane case. She's a long COVID patient. She's 62. And I'm looking, I keep doing her hormones. I did it in her first set. Her total testosterone is 620. Estradiol's 1,230. Wait, hold on. This is insane. I've never seen this.
Where do you get the hormones, by the way? Quest or LabCorp?
This was Quest.
Okay.
No, this is LabCorp. Her progesterone was 13. I'm like, what the hell is going on? So then
She's on hormones?
Oh, yeah.
Okay.
Not right.
Yeah. Do you know how many? What she's...
So then I repeat it. I'm like, okay, I want to repeat this. I was like, maybe this is a mistake because I've never seen numbers like this. I was freaking out.
The only time I've ever seen that is when women are sleeping with men who are using topical testosterone and transferring.
Her husband's not. So then she repeats it, right? She was 2,144.3, her estradiol, or sensitive.
It's like in the hyperstim state.
And her testosterone was 711, and her progesterone was 13, okay? I mean, she has long COVID, but I'm like, how can she feel good like this? This is insane, She's nauseous all the time, nauseated 24/7. So then, and her sex hormone binding globulin's 211. So then I repeat it because I'm floored by this. I'm like, this can't be real. So then I repeat it. Okay, so fine. The total testosterone now is 620. This is better than most of my male patients coming in my door. And her DHEAS it's still high. It's like 24.3. Then her estradiol went from 2144 to 1230. And then her sex hormone binding globulin went up to 229.
Do you know what she's taking?
Yeah.
Have you
ready?
reviewed? Yeah.
She's on estradiol 2.8 milligrams, estriol 0. And then testosterone 3. 1 gram, 1 ml per day equals 1 gram a day.
Is this being injected or is this?
No, it's a cream.
The cream. It doesn't make sense. The numbers don't align with the treatment that she's getting.
And I repeated it.
Yeah.
So I stopped her. I just took her off everything.
Good job.
I was like, go off everything. And then I had her, she was like, but I didn't want her withdrawal and have and feel awful.
I don't worry about that because it's better to figure it out.
Well, I took her off of it, but I did put her back on like after a while. It's been like I think it was like 2 weeks.
How did she feel when you stopped everything or started withdrawing? Because you can do it slowly.
She didn't like notice anything. Like she's been coming in to me for the IVs and stuff. Like I waited, I took her off for a little bit. And then I just gave her a 0.25 patch, and I gave her 100 of
0.25 or 0?
No, 0.025.
0.25, okay.
Like the lowest dose,
right.
just so she'd have a little something. Because
I
didn't want her
how is she done on that?
She's not complaining. I haven't rechecked her.
So that's unusual too.
What should I have done?
What you did was fine, but whenever you're faced with abnormal numbers and you repeat them and the woman that you're treating doesn't seem that symptomatic, it's always best. It's like a machine that doesn't work, unplug it and then replug it.
Yeah, that's
so
what I
stop it
do. Yeah.
and let her withdraw. I sometimes stop it slowly.
But when they withdraw, there was nothing. I mean, I just.
So I would. Reason why you want to stop it maybe slowly by weaning her is if if her body is adjusted to that level, she might miss it more. And of course, women don't like hot flashes and feeling uncomfortable.
No, I know.
And she already had long COVID symptoms. So what I would do is every other day, if you're going to look at this again, maybe a more natural approach would be to say
every other.
Yeah, let's reduce it by half, and then you go to every other day.
So go to like a half a gram every other day. Yeah. Mm-hmm.
And then you wean her off of it completely within like a 2 to 3 week period, depending on her comfort level. Keep her off of it and then retest her hormones, because in a week or 2 or 3, she should be back down to baseline. Unless there's something else going on. And to be fair and transparent, there's nothing that I can imagine that would be behind this besides excessive hormones in a woman who actually doesn't metabolize it very quickly, keeps it around in her body, and she's Okay.
So then... And then after you get her back to like whatever baseline or menopausal level, then I
would slowly start hormone at a time.
Right. That's what I do too. I started her on progesterone first. I always start my patients on progesterone first, and then I start estrogen.
Do you have a reason for why you do it?
Because of the whole thing of not having unopposed estrogen, and I just feel like women tolerate the progesterone better first, but I don't. That's just my.
So that's a great reason, because we obviously all use progesterone even when you don't have a uterus. So that's just the one reason to use it, that you have to use it. But there's one reason to do it, But the other reason I like progesterone, and it depends on how a person presents, is if sleep is an issue, progesterone is really useful for sleep.
I agree.
Right. Okay.
100,000%. And all of these women can't sleep and they're anxious.
Yes. So progesterone really helps.
Yeah,
and I usually start with just 100 milligrams of micronized progesterone. So I would start low, and then I would retest her in like 4 to 6 weeks.
So I usually do that. I test it like around like 6 weeks, similar to that. But most women, I would say, I do usually go to 200. I do get them.
I think 200 is fine. It just depends on the patient and what you're trying to achieve. One of the issues with progesterone is the lab varies its assays. So we've noticed that as well, where they change the assay, and sometimes they'll look for naturally secreted progesterone, and sometimes they look for micronized. So there was a long stretch of time where I then reached out to Quest, because I would see everybody coming in and you couldn't see any progesterone, and they weren't measuring micronized progesterone, so you couldn't see it. But if a person felt well, I would leave it alone. And to that point as well, kind of thinking through this, when a woman who might be 60, 70, 80 comes in and has never been on hormones, you also want to go slow and use a little. And if sleep is not a problem, I start with testosterone, because testosterone will help them feel stronger, lose weight, and also it's better for sugar management and other issues.
Who, like an older woman, you're saying? Like, 65 and older or something like that?
It depends on when their last period was.
And when you're giving them testosterone, you're giving them a cream?
Yeah, it's usually
And where
do
you have them apply to
I have
the
them
outer
apply
labia?
it to non-end terminal hair sites, which is behind the knee and in the fossa of the wrist.
How come some people use like the outer labia?
Because they think it improves libido, and it sometimes does, but I don't find that universally true. Or you do this part of your elbow, the inner part of your elbow, or behind your knee. And sometimes I have them rotated. The only issue with the arm is drawing blood. Well, Robin, that was a great case. Great management, actually. I love what you did. I think in looking at numbers, you're doing great. You're not just trying, you're doing it.
And I'm very conscientious, and I don't want to mess up, and you just want to get it right for everybody.
And you did it right, because when you are faced with numbers that make no sense, because the doses she's getting is not that outrageous, you stop what you're doing again, and then you restart at a lower level while you're assessing how she's feeling. So you don't necessarily want to stop overnight, because she may react to it. So you can wean. You stopped overnight and she still felt well. So what you're doing to approach it and slowly ramp up each one of the other hormones makes sense.
I didn't start, and I don't know how you feel about this too, but I usually, I do progesterone, estrogen, and then I'll add testosterone. It sounds like sometimes, with not my older, more my newly menopausal.
depends what they're missing and what they present with.
True.
So generally that's the default. But I think when someone is in amazing shape and doing everything right and sleep is not an issue, testosterone is a good place. When they're older, you want to make sure you're getting them the sleep if that's an issue, or they need more estrogenization. Let's say they have dyspareunia and uncomfortable, sex life. Initially, I add actually an estrogen cream. So there's a lot of ways to do it for the individual.
And you're fine too, like using like an estradiol cream with like a patch.
That's not a problem, but sometimes it's annoying, and I find patches to be more annoying, even though it could be on a daily basis.
But I mean more because if you're trying to give more, like what I mean is I started using both now too, because I find, or I had done some reading too, that the estradiol cream, in addition, will help with the pelvic and pelvic muscle.
So that's estradiol cream locally.
Right, that's what I mean.
Right.
I feel like that's awesome to get, to give,
Yes, so I almost always, because if women come in with early symptoms, but they haven't really been treated for a while and they've been in menopause for, not the perimenopausal, because that could be subtle, then giving them some cream will hasten the recovery. So we usually start it with several times a week, sometimes every night, and then within a week or so, we reduce to 2 or 3 times a week. And ultimately, when you get their estradiol level higher in their blood work, and they see it, their cells see it, you don't always need the estradiol cream. So then it becomes whenever it's necessary.
Right, but are you getting the same effect with the pelvic musculature or pelvic muscle, the pelvic floor muscles, just giving it orally, or is it help to also give it?
It helps when you jumpstart it until they get a steady state, then you're fine. So most women don't need to continue to do it. It's just an extra step. So why be annoying?
And it doesn't help with
dyspareunia?
Well, that or like
painful intercourse?
Or like having better intercourse?
Yes, it can. And there are other
for
products.
other reasons I don't have to say.
There are other products for that. But in terms of simply making sure her body is up to speed, the usual course, and if they want to continue it, it's up to them.
Right,
because
you can.
Yeah, if you feel uncomfortable, you think it helps, you can apply it 2-3 times a week.
Right.